Hi, thank you for listening to Nursing Chats podcast. I'm Taylor,
I'm Marie.
This is Amelia.
and today we are going to be talking about depression. So, I'm going to start out by talking a little bit about the background of the disease, starting with the pathophysiology, and then Marie is going to talk about the clinical manifestations and nursing assessments and a couple of complications, and also a clinical practice guideline. And Amelia is going to finish out by talking about a research project about a treatment. So I'll go ahead and start with the pathophysiology of depression. According to Lippincott Advisor, the pathophysiology of depression is not clearly defined, but there are lots of theories, according to an article by Gregor Hassler. So I'm going to talk about why there are lots of theories and why we don't have a clearly defined pathophysiology for the disease. And then I'm going to talk about a few of the theories that the article from Hassler mentions. So the reason that we don't have a specific pathophysiology for depression and why we have a lot of theories is because there is a fairly low response to all of the treatment. So that suggests that depression is pretty genetic. And because it's genetic, that means that there are more inter-individual variability, and so there needs to be more specific treatment. And so there's not a specific pathophysiology for the disease. So I'll go ahead and start with the theories by talking about the gene vulnerability theory. According to the article, there were twin studies done, and the twin studies showed that 30 to 40% of depression risk is genetic. And the article also talked about how the genes are affected, and it's not so much one specific gene and one large effect, but it involves many genes with more small effects. And so that makes the disease process a lot more complex. And again, why it's hard for us to put a finger on a concise pathophysiology for the disease. There can also be gene-environment interactions. So a couple of major risk factors for depression are family history, but then also that and a combination of stressful or traumatic events, because the stressful events can cause interactions with the genes and increased risk for depression. So I'll go ahead and kind of transition into the next theory about stress and how stress hormones and cytokines can be a theory for depression. So we release cortisol in response to stress, and as research shows, women do typically have depression more than men. Being a woman is a risk factor for having depression, and researchers believe that's because women tend to have a greater stress response. And then an example of something that could alter your stress response is childhood trauma. So a child who is exposed to trauma or a stressful event might have an altered stress response later in life, which could put them at a greater risk for depression. And all of that, again, involves genes and how those genes interact with the stressful event or the traumatic event. And then some studies show that there are greater levels of corticotropin releasing hormone in patients with depression. The weakness to this theory is that, like I said before, there's just no significant effects of drugs targeting this system, this body system. And so that's why we can't say that this is the main pathophysiology for the disease. The last theory that I'm going to talk about is an imbalance of the monoamines, and this is a theory that I think a lot of people talk about pretty often. We hear about imbalanced levels of serotonin, and that's often the what people think is the cause of depression. And there are a lot of studies that support this. There's a specific study where they depleted or they withheld tryptophan, and that reduced serotonin levels, and those patients had an increase in signs and symptoms of depression. And then there is some evidence that there's decreased norepinephrine metabolism in patients with depression, and some evidence that patients have lower amounts of dopamine metabolites and therefore a higher level of dopamine in their cerebrospinal fluid. But again, because there isn't a treatment that is consistently and effectively responsive, we can't say for sure that this is the pathophysiology of depression. And so the strongest theory for depression is the genetic theory. So now I will have Marie talk about the manifestations.
Awesome, Taylor. That was really interesting. So that was the physiological side of depression, but what are the clinical manifestations of patients with depression? So the DSM-5, which is Diagnostic and Statistical Manual of Mental Disorders, has 5 categories of depression. For depression to be diagnosed, a patient must have at least 5 of 8 signs and symptoms of depression, and I'll talk about those a little later, and must have these every day for at least 2 weeks, lasting most of every day. So major depressive disorder is the first one, and it has 3 subsets. Bereavement after a significant loss, psychotic features such as hallucinations or delusions, and postpartum onset, in which the mother becomes depressed and is at a high risk of harming her newborn baby. The second disorder is seasonal affective disorder, and it occurs during winter months usually because of less daylight. Dysthymic disorder starts in childhood and adolescence, and you only need 3 signs and symptoms for this one, and can develop later in life into major depressive disorder. Premenstrual dysphoric disorder is depression a week before a woman has her monthly period. And lastly, substance-induced depressive disorder is caused from either the use of or withdrawal from drugs or alcohol. So we can see these clinical manifestations in our nursing assessments. Just through observation, the patient will look sad with a blunt affect and have sluggish thoughts or movements or be hyperactive. They might complain of fatigue and hopelessness or worthlessness and talk about social isolation. They may have weight gain or possibly weight loss not from dieting, and their appetite could change either way. These signs and symptoms are not due to the effects of substance abuse or a medical condition like hypothyroidism. The complications that arise from these manifestations have a negative effect on all social interactions. The family, work, friends, the checkout lady at the grocery store are all affected by the person with depression. Basic body rhythms are disruptive, including sleep is affected and can go both ways, either hypersomnia or insomnia. And then the one that every person who hears the word depression thinks of, suicidal ideations or attempts. These suicidal thoughts are reoccurring and persistent. So all of these complications can create a domino effect that pulls the person farther into the black hole of depression. So bringing it all back together, the 8 clinical findings a person must have to be diagnosed with depression is a depressed mood, hyper or insomnia, indecisiveness, decreased ability to concentrate, suicidal ideation, decreased motor activity, inability to feel pleasure, and an increased or decreased weight. So now that we've covered the pathophysiology, clinical manifestations, nursing assessments, and complications of depression, let's look at the clinical practice guidelines, or CPG. So CPG are used to guide processes that are done every day in clinical settings to make decisions easy and efficient to complete. The U.S. Preventative Services Task Force, which I'm going to abbreviate as Task Force, is an organization that compiles research studies done on various diseases and the treatments or screenings implemented in the studies to formulate a clinical practice guideline recommendation. Mostly doctors were involved in creating these CPGs, but a few nurses did contribute. The CPG that the task force has put together for depression is split between two different ones: screening for adults and screening for children and adolescents. The age groups range 18 and above for adults and 12 to 18 for adolescents. Children 11 years and younger, they don't have sufficient evidence saying they should be screened for depression and that it actually might be harmful to screen them. Both of these CPGs have a B rating, the rating system of A, B, C, D, and I being insufficient data, by the task force simply means they believe this service to be moderately to substantially beneficial to use, and they suggest that healthcare should provide this service. Many types of the screening that is used is the patient health questionnaire, and there's one that is specific for adolescents, and then several different depression scales for geriatrics, hospital stays, and postpartum and pregnant women. The CPG suggests that if the screening is done and the results are positive for depression, that quick treatment should be available in the facility the patient was screened in, or that some place nearby be recommended, such as a counseling center. So looking at the treatment recommended by the task force, for adolescents, selective serotonin reuptake inhibitors, SSRI, had a better outcome than psychotherapy and collaborative care. And collaborative care is that adolescents and the parents choose a treatment and have regular follow-up appointments with counselors. So once again, the SSRI medication was better for adolescents than psychotherapy or collaborative care. For adults, however, the antidepressants and psychotherapy were the best options, either separate or together. And this was especially beneficial for older adults living in communities. For pregnant and postpartum women, antidepressants were mostly avoided due to the negative effects on the baby. So women were told that they had depression and had follow-up visits with their providers to discuss their depression. So that is the CPG's the task force recommendation. So now we're going to go to Amelia and see what her research has found.
Awesome. Thank you, Taylor and Marie, for the pathophys and the clinical manifestations and the CPG guidelines. Those were awesome. So as Taylor and Marie both mentioned, being a woman increases your risk for depression. And so I really wanted to highlight just that women, especially pregnant women specifically, their treatment options are more so limited, but just because their treatment options are limited, that doesn't negate the fact that we need to be treating these individuals. My review, the article that I found on this, I'll be referencing it several times, but the title is Depression in Pregnancy and Ways of Dealing. And really its aim is it says the aim of this study is to investigate how effective treatment for depression during pregnancy. And so it highlights the fact that, as Marie stated, for adults, the current CPG treatment is, the CBT, which is cognitive behavioral therapy, paired with medications. But as I'll get into in a little bit, medications haven't always necessarily been approved in pregnant women, and they could actually be harmful to the baby. And so a lot of times we see pregnant women with depression being treated only with cognitive behavioral therapy. And this systematic review kind of looks at some different therapies that have been used in the past for pregnant women and determines if they are effective or not. So like I said, the purpose of the study, it makes sure that we understand that it's necessary for pregnant women to have effective alternative treatments available, because those medications may cause harm to the baby. And some of those harms include higher chances of premature birth, a development of preeclampsia, postpartum depression, dysfunction of the hypothalamic pituitary adrenal embryo, premature birth, low birth weight, lower than normal neuromotor performance, changes in behavior, physiology, and even the biochemistry of the baby after it's been born. And so those are definitely things that we want to avoid in pregnant women, and we want to make sure that cognitive behavioral therapy is an effective treatment, so that these women can still be treated for depression without harming themselves or their baby. So, like I mentioned, it is a systematic review approach. It kind of goes over 3 different studies. One of the studies that it looks at used morning light. Another one used acupuncture. And then the third study, it went over a couple different types of CBT therapies. The participants, so in total, with all 3 of those studies, there were 844 participants, but we're only going to be looking at the cognitive behavioral therapies because that's the one that the CPG supports. And so the participants for the CBT treatments, there were 767. And of those 767, 17 of those were just in the cognitive behavioral therapy. The rest of those were in other therapies such as psychotherapy, counseling, group therapy. 30 of them did medication with CBT, so that combined. But 17 of those were with the cognitive behavioral therapies. And so they emphasize that treating depression early is very key, especially in pregnant women, just because with that cognitive behavioral therapy, it's a process. You know, it's not just like the meds aren't going to work right away. The therapy itself is a process, and so being able to start that treatment sooner will result in better outcomes. And then the results of this study showed that there were 3, I guess, most effective treatments. And those 3 were pharmacotherapy, group therapy, and then, of course, cognitive behavioral therapy. And so the importance that these findings have is that even though oftentimes when a pregnant woman is being treated for depression, if pharmacotherapy is used, it does typically result in an effective depression treatment. However, that also increases the risk of harm on the baby. And so because of that, doctors are less likely to prescribe these medications for pregnant women. And so we need to make sure that, you know, cognitive behavior therapy is equally as effective as medication, and this study shows that it is. So some nursing implications that this study has, it mainly it wants us as nurses to advocate for these patients. We need to advocate for the best research and the best evidence, and make sure that our patients are being provided with the care that they need to treat their depression, and also to make sure that baby is being taken care of in the best way possible. And then also just that early treatment. And so as nurses, we are often on the front lines of assessing our patients. And so we can actually intervene earlier than sometimes maybe a doctor or another health provider may be able to, because we can recognize those signs and symptoms. And so as Marie was talking about those kind of 8 key signs and symptoms, I think it's important that we as nurses are constantly assessing our patients, even if it's just in the back of our mind, you know, just always be looking for those key signs and symptoms and asking those questions, you know, how are you doing? How have you been feeling lately? Especially amongst our pregnant women patients. And so with that, we can, if we assess early, we can treat early, and especially with the cognitive behavioral therapy, we can protect the babies from potential pharmacological adverse effects until those medications have been proven safe, until we come out with more that are better for both mom and baby. And then also, because we are able to treat these patients and then allow for the safe delivery of baby, I think that it also just provides a way for us to connect with our patients, you know, and interact with them on a deeper level. We're not just providing physical care, we're also providing mental care. And that's huge, especially for a mom to be, you know, they want to know that they're going to be taken care of, not only physically, but also mentally, because it's kind of a big deal to have a baby, you know, and especially for first-time moms, it can be very, very overwhelming. And I think that it might sometimes be hard for first-time moms to admit that they're overwhelmed, because there's a lot of stereotypes around that. And so it's really important that we as nurses are especially vigilant about asking those questions and assessing for those signs and symptoms so that we can intervene if necessary. So a very interesting article. I really enjoyed reading it and looking at the different research that it went over. And yeah, I learned a lot. So to summarize, Taylor.
So at the beginning, we talked about the pathophysiology of depression, and we concluded that most studies support that depression is mostly caused by a genetic vulnerability, which makes treatment more individualized per patient. And we reviewed a few theories about the pathophysiology of depression, but again, studies support the strongest theory is that it is a genetic disorder. Marie?
Yeah, I talked about, like, how do we see this in the hospital? You know, the 5 different types of disorders for depression, just what to look for in our nursing assessments, the fatigue, the sluggish movements, suicidal ideations, and then just the complications that can come along with someone who does have depression and how it affects all parts of their life. And then I talked about the CPG for depression and just what's used to screen for this and some of the treatments. And yeah, and Amelia.
Yeah, and I just talked about a research article that I read and reviewed that went over the specific CPG treatment for pregnant women and how important it is for us as nurses to be able to recognize the signs and symptoms because early treatment and prevention and early intervention is key for these patients, and how cognitive behavioral therapy is an effective treatment for our pregnant women that cannot take pharmacological interventions. So yes, thank you, and we hope to see you soon.